This video presents the arthroscopic treatment of scaphoid enchondroma. We have a 20-year-old male who fell from a sports injury 4 months prior to his presentation to us with persistent wrist pain. The X-ray shows a right proximal pole scaphoid fracture with cystic changes within the fracture site. A CT scan was performed which showed a minimally displaced scaphoid proximal pole fracture with cavitation seen within the scaphoid bone. The MRI also showed similar findings that is highly suspicious of a scaphoid enchondroma. We begin by performing a core decompression and harvesting cancellous bone graft from the distal radius using a Jamshidi needle. Preliminary cannulated K-wires were placed at the distal pole of the scaphoid bone. We begin our arthroscopic assessment at the radiocarpal portal followed by the mid-carpal portal. This is the mid-carpal ulnar portal view showing the pathological fracture site. We could appreciate that this is a minimally displaced scaphoid fracture. The overall joint cartilage looks pristine in this case. As for the enchondroma, we used a straight and angled dental curette to curette the enchondroma from the distal aspect of the scaphoid bone as well as the proximal pole of the scaphoid bone. You could see that the curette is currently facing the proximal pole of the scaphoid bone, and the black asterisk indicates the location of the scapholunate joint. When performing this procedure, one has to be careful not to spill the content of the enchondroma into the radiocarpal joint. One option to remove this tumor is to connect the shaver to a small suction bottle. However, in this case, we removed the enchondroma manually through a bigger portal incision to ensure that there is no spillage along the portal track. In addition, we used a high-speed burr as an adjuvant therapy to ensure that the small crevices with enchondroma is removed. This was how the distal aspect of the scaphoid bone looked like after removal of the scaphoid enchondroma, as well as proximal pole of the scaphoid bone. The cancellous bone graft that was harvested from the distal radius was then used to pack into the scaphoid fracture site using a Jamshidi trocar. We packed the bone graft from deep to superficial with the help of a Frias elevator or an arthroscopic probe. This is followed by tissel glue application to prevent bone graft migration. This picture shows how the bone graft packing should look like prior to tissel glue application. The scaphoid bone is then fixed with a 2.5mm headless compression screw followed by a scapholunate pinning with a 1.2mm K-wire. The scapholunate wire was placed for added stability due to the small size of the proximal pole. Post-operatively, this patient was placed on a scaphoid cast for 4 weeks with initiation of finger mobilization. This is followed by 8 weeks of scaphoid splint with initiation of dart thrower's motion. The scapholunate wire was removed by 3 months, and a CT scan at 6 months showed a complete union of the scaphoid bone. This is the post-operative outcome at 1 year showing good range of motion and a recovered grip strength compared to the contralateral arm. The patient is pain-free and a quick dash score was 2.3%. We also performed an arthroscopic assessment at 6 months after surgery, which showed a complete union of the scaphoid bone. The picture on the left was taken right after packing of the cancellous bone graft. And the picture on the right shows remarkable incorporation of bone graft as well as cartilage remodeling during arthroscopic surveillance.